Some is a very, very important complication. Anybody who uses ICI should be able to treat the priapism. Unless you are able to treat the priapism, don't give ICI, because if the priapism extends beyond 4 hours, the person may get permanent ED, because the nerves will be damaged, cavernosa will be damaged, and he may end up in permanent ED. Good morning, everybody. Thank you. At the outset, I'd like to thank Dr. Ajay Varghese. He has taken so much pain to organize this one. He has called me about at least 12 times, if I remember correctly. So that shows how many times we would have called so many other speakers and made this day a successful one. And that too, organizing in such a big level at the capital of the city, capital of the country, is a great privilege and honor to all of us. I request all of you to give him a very big hand for this successful discussion. So as you know, as Dr. Ajay said, the sexual medicine, you should come to the modern medicine, and all of us, all the qualified doctors with MBBS should be aware of this specialty, and that comes with investigations also. So this I am going to take up color Doppler penis, and I am going to cover with this under the following subject: introduction, equipment, anatomy, indications for color Doppler penis, technique, interpretation, disorders, complications, aftercare, and conclusions. Penile Doppler scanning is also known as penile Doppler scanning. I will call it as PDS in short to save the time. And it is done to assess the penile anatomy as well as penile pathological conditions, especially in case of erectile dysfunction and other penile disorders. It is a non-invasive or less invasive or minimally invasive technique, and it should be done by a trained radiologist or a sonologist or a urologist or a sexologist. So I underline the word trained because I see so many reports given by even the qualified radiologists of the color Doppler penis where they wouldn't have given the correct report because they wouldn't have studied the correct anatomy and physiology of the penile circulation and also penile pathology. This is about how we conduct the PDS. It is done on the ventral aspect of the penis. The transducer used, you can see the equipment also. You have to use high frequency, a small probe, usually of high frequency, 7.5 to 10 megahertz, 12 megahertz is used. If you use a regular probe, you won't see the penile anatomy as well as the penile circulation. The probe is moved over the ventral aspect of the penis and images are obtained. You can see the small probe. This is the small probe. And it should be high megahertz. Image acquisition, the ultrasound emits the echoes, and the echoes which goes to the body, it is taken back by the same transducer, and the images are produced on the TV monitor. This is the sono anatomy. You should be very familiar with the anatomy. Unless you are familiar with anatomy, you will not be able to diagnose the lesions properly. See, this is the tunica albuginea, and these are the corpus cavernosa. This is corpus spongiosum. This is the urethra. This is the dorsal penile vein, and these are the cavernosal arteries. You should be able to pick up these cavernosal arteries, helicine arteries, and the superficial dorsal vein. These dorsal penile artery. You should not mistake the dorsal arteries with the cavernosal artery. Cavernosal arteries are different and dorsal arteries are different. The waveform of these arteries will be totally different. That's why you should be able to pick up these. And buck fascia you should be able to diagnose, and also the septum. You should be able to pick up all these anatomical features when you see the picture in the scanning. And arterial supply, you should be very familiar with the arterial supply to pick up the lesions in the penile, penis. This is the internal pudendal artery, which divides into the dorsal penile artery and cavernosal artery. And these are all the helicine arteries and circumflex arteries. There will be intercommunicating arteries also, and this is the corpus cavernosum, this is corpus spongiosum, and this is the bulbourethral artery, which supplies the bulbous glands also. This is the venous drainage. You should be familiar with the dorsal penile vein. You will be seeing the dorsal penile vein. In fact, whenever you see the penis, you can see the vein very clearly, and superficial dorsal vein also you can see, and these are all the tributaries, and this is all these veins will lead to prostate venous plexus, and the bulbous vein supply goes to the internal pudendal vein. This is the image of the penis. You can see the corpus cavernosa, corpus spongiosa, and also the septum also you can see, and this white line, thick white line, that is the tunica albuginea. This is the longitudinal section of the penis with the color doppler. You can see the cavernosal artery. The color doesn't say that it is artery or vein. The color depends upon whether the blood is flowing through towards the transducer or away from the transducer. The same penile artery, if you put the transducer at 30 degrees towards the artery, it looks red. If you keep the transducer, same transducer, over the penile artery or the cavernosal artery, away from the artery, that is 30 degrees, if you reverse it, it looks blue. So, blue or red doesn't say that it is artery or vein. Artery and vein, they look same. The veins will be looking entirely differently, that I will show you later on. So, the same artery in the same different direction, it looks blue. This is the transverse section. You can see the penile arteries, the cavernosal artery. They are looking both blue and red because it depends upon whether the blood is flowing towards the transducer or it is going away from the transducer. This is the corpus cavernosum. This is the cavernosal arteries. They just look like two eyes when you take the transverse section in the PDS. In the longitudinal section, you can see the cavernosal arteries, and these are all the helicine arteries. They are beautifully seen when you do the scanning. This is the protocol, how we do the scanning. The method should be explained in detail to the patient because you are doing it with invasive technique, that is with the giving the intracavernosal injection. Anytime you give any injection, you should explain to the patient the possibility of so many other adverse reactions, including priapism. So, you should take written consent. Without written consent, you should not do ICI injection because the patient may land up in priapism. That is very, very important, and there should be completely private, calm atmosphere for the scanning. You should not do this scanning just in any other scanning room because it requires erection, and for erection, the patient must have privacy. And the scanning should be done first in the flaccid condition. So, the soft tissue scanning should be done. The calcifications, the flakes, plaques, and other lesions should be ruled out, and then only you should give the ICI injection. In ICI injection, you should do the scanning, and if the patient refuses ICI injection, or if you are afraid of giving the ICI injection, you can give it sildenafil citrate oral tablet also, but it should be fast dissolving. You should go for Penegra Express tablet, that is sublingual tablet, which dissolves within 15 minutes. Or nowadays, the oral spray of sildenafil has also come. It dissolves within, it is absorbed in the mouth within 10 minutes. That also can be tried. But the disadvantage with the oral tablet and spray is that the effect is not that good. You may not get the erection properly, and whatever the results you get, they are not satisfactory. Hence, ICI injections are best. The technique is the patient is in the supine position, entire penis should be examined. First, morphological evaluation of the penis should be done, and then it should be done with erection under ICI injection. The injections you can use either prostaglandin E1 or you can go for bimix, that is papaverine with prostaglandin, or trimix, that is papaverine, phenethylamine and prostaglandin. If monomix injection fails, you go for bimix. If bimix fails, you go for trimix. So do the examination first in the plain scanning, then with the injections. The injection should be, after the injection, you should do the scanning with 5 minutes interval. If you don't do the scanning with 5 minutes interval, you won't get proper results, because just doing one examination before giving the injection and after 30 minutes, it won't give the correct picture, because you have to do under 5 minutes interval. the first 5 minutes, you get, it will be in the flaccid state. In the flaccid state, there will be monophasic minimal diastolic flow. That is, only the systolic flow will be there. At the 10th minute, there will be filling phase, that is increasing both systolic and diastolic flow will be there. And at the 15th minute, there will be tumescence phase, that is, the penis will be slightly enlarged, and there is appearance of dicrotic notch at the end of the systole. I am going to show the picture. And in full erection, at the end of 20th minute, the end diastolic value decreases to 0, because the blood is only going towards the penis, it is not coming back. That will be peak systolic volume. And at the end of 30 minutes, there will be rigid erection, and after the rigid erection, there will be reversal of the flow. That is, the erection starts coming down. These are the parameters, the words we use in the hemodynamic parameters. The peak systolic volume, that is called as PSV, end diastolic velocity, that is EDV. Sorry for my bad throat, because of the yesterday night, the temperature they had kept it, I think 17 degree. I got so much chills, the sore throat got. So otherwise my voice used to be quite good. So today I don't know what happened, but I am sorry for it. Anyhow, you can read the slides instead of listening to me. The other hemodynamic parameters we use are resistance index. PSV and EDV are expressed in centimeters per second. PSV corresponds to the maximum flow rate during the systole. That is, PSV is the maximum flow the person attains after giving the ICI injection. End diastolic velocity defines the residual flow in a vessel at the end of the diastolic phase. At the end of diastolic phase, usually the end diastolic velocity should not be more than 5. If end diastolic velocity is more than 5, that means there is venous occlusive disease. Resistance index reflects the peripheral resistance to the flow, blood flow, and is expressed in the following formula. Ri is equal to PSV minus EDV divided by PSV. Usually most of the equipments, they will have inbuilt formulas. So you need not calculate this. The Ri and Pi, they will be deficited on the image itself, and in the picture itself you will get it, and in the results, most of the equipments which come nowadays, they have this inbuilt formula. Another index which we measure is the pulsatility index. It is an intrinsic property of the cardiovascular system, governed by the resistance of the differential across the arterial orbit. When evaluated as a deprived flow parameters using pulsed wave Doppler, the formula is Pi is equal to PSV, that is minimal dV, the diastolic velocity, divided by mean velocity. That is PSV minus minimal diastolic velocity divided by mean velocity. That is the formula. But most of the equipments, they have got this inbuilt measures. You need not calculate. The computers themselves, they will calculate and gives the measurements. So normal values are PSV. Most of the times when you see the images, if it is PSV is more than 30 centimeters per second, it is normal. End diastolic velocity should be less than 5 and PI and RI should be less than 8. The blood flow patterns are as follows. If there is retrogrowth flow in the veins, then it is a veno-occlusive disease. That is venous failure. In the common terms we call it as, that is the veins fail to contract at the end of the systole. If the veins doesn't contract after giving the ICA injection, that is the blood is flowing back towards the body and the penis is unable to retain the blood which has been pushed by the systole, by the penile artery, that is cavernosal artery, and the blood doesn't remain and the pressure doesn't accumulate in the penis to get an erection enough for the penetration. That is called as veno-occlusive disease, that is disorder. And arterial occlusive disease is when the penile arteries are narrow or they have got atherosclerosis or the blood flow through the penile artery is less, then it is called as veno-occlusive arterial occlusive disease. It is similar to coronary artery disease or carotid artery disease, where the blood flow to the brain or to the heart is less. Similar to that, it is arterial occlusive disease. Most of the times it occurs due to atherosclerosis or narrowing of the blood vessels. These are the pictures we get in the flaccid phase. In the monophasic phase, you just see the systole. Peak systolic velocity is there. There is no diastolic flow. In the filling phase, both is above systole and diastole. There is blood flow towards the penis. That is in the filling phase. In the tumescence phase, there is both the blood flow towards the penis and also diastolic flow is also there. At the end of the erection, full erection, only systole is there. There is absolutely no diastolic flow. This is normal picture. If you get this normal picture, that means the person is getting full erection, because the blood is getting pumped into the penis. It is not coming back. So at the end of 20th minute, if you attain this one, then it is normal. And this is fully rigid picture. In full rigid penis, there will be absolutely no blood flow. Sometimes you cannot pick up the penile artery and coronary artery, cavernosal artery at all, because the blood flow completely stops, because the pressure built inside the penis is so much, hardly there is any blood flow towards the penis or away from the penis. That is the rigid penis. This is the pathological picture of hemodynamic interpretation. You see, in the normal this one, the PSV should be more than 30 centimeters per second. That is normal. If you get this picture, then you can declare that the person is normal. And if there is arterial insufficiency, the peak systolic velocity will be less than 30. So usually 20, 25 like that. This is a typical arterial insufficiency picture. And also the arteries will be narrowed if you see like this one. And in venous occlusive disease, that is venous failure, what we call it as venous vascular failure or venous occlusive cavernous failure. That is, the veins doesn't contract at the end of giving the injection, even after 15 or 20 minutes. That is, the veins continue to be open. The blood, whatever it is flown towards the penis, it goes back to the circulation through the vein. That is called as veno-occlusive cavernous dysfunction. Dysfunction is, it is not contracting. This is the picture you get. What happens is, even in the diastole, the blood flows. That is, the blood is not getting filled into the penis. It is coming back to the circulation. That is called as this one. The end diastolic velocity will be more than 5 centimeters per second. Other diseases which we can pick up easily, even without doing ICA injection, is the Penile disease. You can see the calcifications very clearly, plaques and calcifications. And other indications for the PDS is the post-operative scanning of the patients with penile implants. You can see the fluid filled in the bulbs which have been put into the penile implant. Other, you can see, you can use the PDS for patient monitoring, for giving the tablets treatment, PDE5 inhibitors, unexplained penile pain, also you can use the PDS. And for research purposes, for clinical studies also you can use this PDS. And erection hardness scoring, that is after giving the PDA, the ICI injection, these are the scorings. If there is no erection, erection 0, EHS, slight tumescence. In slight tumescence, the patient is unable to penetrate. That is 1. In 2, the tumescence is there. It may be, he may be able to penetrate, but not rigid enough. That is EHS 3. 4, firm enough for penetration, and EHS 5 is full rigid erection. So risk, the most important risk is the priapism and allergies to the injection. Priapism is a very, very important complication. Anybody who uses ICI should be able to treat the priapism. Unless you are able to treat the priapism, don't give ICI, because if the priapism extends beyond 4 hours, the person may get permanent ED, because the nerves will be damaged, cavernosa will be damaged, and he may land up in permanent ED, and he may sue you for medical legal purposes, and he will be in trouble. So unless you are able to treat priapism, don't adventure giving the ICI injections. Other complications, pain, infections, discomfort, allergy, bruising, edema, hematoma, this can be easily tackled. So friends, PDS is a very, very important investigation. The persons who come for ED or for any other penile disorder, especially with a plaque, bent penis, with fibrosis, with lump in the penis, or pain in the penis, they require this PDS, because the person will also be happy because you have investigated him properly, and also it gives confidence to the patient that he has been examined properly and he may be treated better also. The only thing is, before giving ICI injection, be careful not to give ICI injections unnecessarily, because you may land up in priapism. If you and also whenever you are doing PDS, see that whatever the precautions have to be taken for PDS, they are taken properly and interpretations are done properly. Thank you very much. Sorry for my bad throat.
Thank you very much, sir. In spite of your bad throat, you gave a wonderful presentation. And I request Dr. Nilima ma'am to kindly come and felicitate Dr. Sharath, sir.
Yeah, any question? Yeah.
Any question, please? Sir, Mike.
Can I know where the pentolamine is available and where the sildenafil spray is available?
Sildenafil spray, the one recently one company came. I'll give the address. He has given me the sample, so it's working nicely. You have to just spray 2 puffs into the mouth. Each puff delivers 25 milligram. So 2 puffs will give 50 milligram. That's enough. And it gets absorbed within 10 minutes, just like sublingual tablets. I'll give the name of the company.
We are using chlorpromazine in place of pentolamine, because the pentolamine is yet not available in India. And one suggestion I would like to give: before giving intracaverous injection, one should have rule out the sickle cell anemia.
Yes, yes, sir.
If we are not able to rule out the sickle cell anemia, patient will turn out to the priapism. And one more investigation, I would doing it daily before giving intracaverous injection. If the priapism occurs, then we have to give diluted phenylephrine or diluted adrenaline. So we have to rule out the ECG is normal or abnormal. If there is any cardiac lesion, we cannot give this diluted adrenaline and diluted phenylephrine.
I agree with you.
Like spray, we have the now sildenafil comes in the powder form. You just have to put.
Yes, it's available. It is
Same
available
Panagra
by
Express, you can powder it and give it.
It is in the by the name of the direct.
Yeah.
Direct, it is available. Powder form, it is absorbed easily. And nowadays it is available in a scheme also. Yes.